All right. So the following is a brief introduction to some learning theories to put some perspective on how and why people learn. And I want you just to think about it as we're going through the four main theories on what worked for you, how you've seen these theories utilized in different classes that you've had, and what might be most effective when you're teaching different things, again, with how you learn, but also how patients will learn. So these are the objectives that this lecture is tied to, talking about how patients and working with others may be affected, developing strategies in communications, and applying educational theories to begin to be effective in that area. So, learning theories and the discussion about how people learn has been talked about for thousands of years, back to the way back to the Greek philosophers. Everybody's kind of thought about how do people learn and why do people learn. And two of the main, or I should say, two learning theories that initially were developed were Plato, the Greek philosopher, who postulated that knowledge is innate, that at when somebody is born, they have all the knowledge that's already embedded within them, and it's the function of the teachers to help the learner recall what the soul has already learned and to bring out what's already there. Opposite to that, 2000 years later, British philosopher Locke postulated that infants are born with a blank slate, tabula rasa, a blank slate, and they have no knowledge, and it's a teacher's role to provide experiences that would fill that blank slate with knowledge. Now, I think we know that it's probably a neither one of those are true, right? So at this point, there are dozens of learning theories to think about how people learn. And so then using that to develop activities to help people learn. So we're just going to talk about four of the primary learning theories. And you can, again, think about how this relates to how you've learned, what works for you, and does it change with different setting? Does it change with different skills or different knowledge? And how might you use that with patients going forward? So the first is the behavioral learning theory, or behaviorism. This comes from experimental psychologists, specifically Skinner and Thorndike, and this theory rests on observations that behaviors that are rewarded, that are positively enforced, would reoccur. So if you if, for an example, if you get high praise for your accomplishments, if you get high grades for good work, then you're going to do more. So within this theory, you think about practice with feedback, and if that feedback is positive, you're going to learn more, and you will eventually master the activity. So this is a foundation for performance-based education, where you have to where mastery learning occurs when you have the opportunity to practice that behavior and constantly receive feedback until you perfect it. The cognitive learning theory emerged when the limitations with behavioral learning theory were discovered. Not everything is, you're not successful just by rewarding positive feedback. So cognitive learning theory talks about learning that is an active process, and that you develop knowledge structures, and then you put perspective on these knowledge structures. You try to connect knowledge structures in order to make something clearer. So again, you develop knowledge structures. You then put perspective, and you reason regarding these knowledge structures, and that's important for problem solving and for critical thinking. So I think an example of this would be if you have an injury. So you have a rotator cuff injury, and so you would build pieces of knowledge and then connect the dots. So first you would identify the muscles and the nerves and the tissues that are involved with that injury, right? And then you learn to understand the relationships regarding the tissues that are involved, and then you will understand the biomechanical principles of that are happening within that injury, and then you will work to solve the problem. So a foundation of this is that there's a hierarchy to learning, that we learn things from simple, that start as simple and concrete, and as you learn and gain perspective and develop these more complex knowledge structures, you learn and you can work in that complex abstract area. So you learn facts and then concepts and then principles and then problem solving. So you really think of it as a hierarchy of learning. The experiential learning theory comes from the foundation that experience and reflection on that experience are central to learning. So this theory actually comes from John Dewey, who was an American educational philosopher, who talks about experience and reflection and active learning. And then he also adds into this theory that you need to be learning in authentic experiences. So learning in real life situations are most successful and essential for that learning to occur. Within this learning theory, Donald Schoen talks about different types of reflection that are important in the experiential learning area. We talk about reflection in action, reflection on action, and reflection for action. So reflection in action occurs during the activity, in the midst of the action. And then during that activity, as you're reflecting on what you're doing and what's occurring, it allows for a modification of the situation as new information occurs. Reflection on action occurs after the activity. So after you stop, then you look back and reflect back on what occurred in your head. You make sense of what happened. Were you successful? Were you not successful? What do you need to change? What worked? What didn't work? And that you use that as a process of learning and changing activities going forward. Reflection for action involves planning for future encounters by thinking back on past experiences and deciding, again, what worked and what didn't work. So you link those past experiences to anticipated future events. And so now that I'm going to do this activity again, what do I need to change? What do I need to do to be successful? Okay, last learning theory is the social cultural learning theory, which is a type of constructivist learning and learning theory. And within this theory, the thought is that learning occurs in the social or practice settings. So learning occurs in these communities of practice, and learning is situated in these communities of practice, and then by engaging and participating with others within this social setting, learning is facilitated. So meanings are socially constructed in these communities of practice, and that helps with learning. And if you think about an example of this, working in the clinical setting would be a good examples of this, right? Because you work socially with others. While working with others, you develop and facilitate self-efficacy. And as you get more confident within working with and around others, it helps to enhance your participation, and therefore enhances the learning within that setting. So role models and mentors can have a real positive impact in this constructivist social cultural theory. So now we'll go on just a little bit. Those were just some basic general learning theories, and now we're just going to move on to this is the beginning of chapter 15, where we talk about health behaviors and how to help people learn to change health behaviors and what is involved in effective patient education. So if you think of health behaviors as a series of actions that we do all the time to maintain, to promote, or to improve your well-being. So this is, what people do in terms of screenings and health promotion activities, in treatment of disease, all areas that you will be educating folks, and their beliefs and how their behaviors affect them can affect the way they learn and affect what activities you need to provide for them to help them learn. So some health belief theories, these are all listed in chapter 15, so read through them, but I'll describe them really quickly. The health belief model proposes that proposes that the likelihood of an individual to do something to protect against a health threat is related to his perception of the health threat. Specifically, 4 areas regarding that health threat, if you will. Number 1 is the person's susceptibility to the health threat. So how likely is it that I'll have this problem or that I'll get this disease? Number 2, the severity of the health problem. So how severe would this disease be if I got it, right? If I encounter it. Number 3, the benefits of the recommended behavior. So what will I gain by doing this? And number 4, the barriers of the costs, the barriers or the costs of changing this behavior or performing this behavior. So the example that the book gives is smoking. Cancer, you can get cancer from smoking, so the behavior that you should change is to stop smoking. So that the person's thought process in this model goes from how likely is it that I'll really get cancer if I stop or if I continue to smoke? If I do get cancer, how serious is that? Will it have a big impact on me? So number 3 then, what are the benefits? What will I gain by stopping smoking? Number 4 then, what are the costs of doing this? So will it cost me a lot of money to stop smoking? Will I have to pay for medicines or drugs or something to go on with this? Or what is the cost in terms of, am I going to gain a lot of weight, which for some people may be a barrier to do this? So what are the obstacles that might stand in your way? So those are things that people put into perspective in the health belief model. The locus of control model is a pretty widely accepted theoretical approach that talks about our perceptions of the outcomes or the rewards of this behavioral change are either under our control or out of our control. And so think about it. If something is under your control, your belief is that if I change what I do have an effect. It will make a difference. Versus something that's not under your control, that's under external control, is the thought that I have no choice in this. Fate has already decided what's going to happen. The powers that be have already decided what's going to happen. So whether I change my behavior or not, I have no control. So folks that have an internal locus of control will often be more successful in changing behaviors because, again, they feel like they have some control, versus those that have an external locus of control, or feel they have an external locus of control, that they have that their behaviors won't really change anyway, or they won't have any effect anyway. So the self-efficacy model kind of comes or is intertwined with those social learning theories, where that individuals has the sense that they can be successful in carrying out a behavior. So if I think I can do it, I think I can be successful, and I'm confident, then you're going to be more likely to change that behavior. So this self-efficacy is influenced by a number of things. So it's influenced by your past experiences. Were you successful in the past? It's influenced by observing others. Are others successful, and does that behavior change make a difference? And influenced by support of others. So are others supporting your behavior change and helping you to facilitate that? That all adds to your self-efficacy. Alfred Bandura talks about or adds to this theory by talking about the environment and how the environment helps a person make changes and can influence their changes and their choices. So within self-efficacy model, breaking down the activity into small, easily managed pieces can help a person be more more successful and gain self-efficacy. Being able to change activities within their environment to make it more doable, if you will help a person have greater self-efficacy and be more successful. The theory of planned behavior comes from Asgen, and he talks about social influences and intention that are important in addition to self-efficacy. So, there's these three areas that explain individual behaviors, tend to be the behavioral intentions, so the attitudes of the behavior, the person's perception of subjective norms, so the attitudes of others that can make you more successful or facilitate your learning. So family and friends' beliefs about that behavior, and if that behavior is good or bad, will help promote your the thought process and the behavioral change. And then again, the individual's perception of control or difficulty in changing that behavior will also affect a person's being successful. So that's that theory of planned behavior. When you're talking about all three of those, the behavioral intentions, the individual's perceptions, and individual's perception of subjective norms, and individual's perception of control, all affect a person, how a person is influenced and their behaviors. The health promotion model builds on some of these ideas and identify modifying factors that may influence a person's perception with self-efficacy. So Pender identified modifying factors that influence a person's perception of self-efficacy, including things like the demographics, their biological characteristics, interprofessional influences, situational behavior factors that are all incorporated into self-efficacy that may help a person change their behaviors. So the trans-theoretical model to behavior change is an important one, and it's used a lot in current health literature and current health behavior change model. So we'll talk about that one more in a second, because we do want you to know this. But the trans-theoretical model talked about the stages of readiness and a person's readiness to change, and how we intervene at these various aspects of readiness that can help a person be more successful. Motivational interviewing is a cognitive behavioral approach that's based on the trans-theoretical model. So this is helping a person understand where they are in their readiness to change, interviewing and interacting appropriately within each of those stages to help the individual understand their thought process, their emotional reactions, how they relate to those behaviors, and how you can challenge some of those habitual thought processes to provide alternatives to help a person be ready to want to, and to facilitate their change in their behaviors. So trans-theoretical health model, there's a table on page 268 so please refer to this. Trans-theoretical health model talks about 5 stages of readiness that a person goes through when they're changing a behavior. So what's important to know here is what the stages are, and what your action or the health professional's action should be within those stages to help facilitate your patients or your clients' change in the behaviors. So the first stage of readiness is pre-contemplation, which is really when the patient's not attending any changes. So they don't have any, at this point, they have no intention to change. They have maybe heard about, I should exercise, or I should quit smoking, or I should eat better. But they have really at this point no intention of changing whatsoever. So if you have a patient that maybe this is the first time they come to your clinic and they have no intention of changing how they're doing things, our role here is to help the client identify their priorities and their lifestyles, and hopefully provide some insight to those negative risk behaviors, to develop rapport and trust so you can help them understand that behaviors should change and why they should change. The contemplation stage is when the person has decided, okay, you're right, I need to change this behavior, and I'm going to start within the next 6 months. So not right away, but you're thinking about it, you're going to change within the next 6 months. So our role, the health professional's role in this stage, is to really provide those motivational messages, to really give the person and provide the person the pros and cons, why it would be important, what's the benefit of making this change. You're supporting their decision making. You're tying these decisions into some very concrete goals, and you help them evaluate the pros and cons so they end up changing, and we change in a way that will be successful for them. The preparation stage is when the person is actively planning to change within the next 30 days. So within this stage, our role is to seek commitment from the client that they're going to change, and they're going to start on a certain date, or they're really going to make a concrete decision to start. You're going to support this decision with strategies. So this is when you're giving a person resources, you're giving them coping skills, you're really helping giving them some of the concrete information and activities that will help them be successful with the behavior change. The action stage is when the patient has already decided and started to make that change. So they're initiating the change, and it's initiated within the last 6 months or so. Right? So now you're supporting and you're encouraging all those positive changes. You're providing additional resources that may help to continue to facilitate the change. You're teaching them self-management strategies to avoid relapse, or how to recover if there is a relapse. So this person, the behavior has already changed, you're doing the activities, and you're supporting those activities to keep them going, to help the patient continue to be successful. And in the maintenance stage, the person has successfully modified their behavior and has changed the behavior and has been successful for at least 6 months. And now you're talking about activities and education to help prevent relapse, to encourage long-term change, and to review strategies for managing the situations that might trigger the relapse, to reinforce the new habits and achievement of goals. So I want you to think about the trans-theoretical health model specifically, and if a person comes to you with very deconditioned, and your goal is to help them start an exercise program, what would that look like within all of those stages within the trans-theoretical health model? And we'll put that into some perspective in class. So then the person, or you've decided to do some activities and provide education to help a person change a behavior. There are some specifics and recommendations regarding instructional planning guidelines. So these are kind of just real general guidelines to think about if you're planning an educational program. Right? What's the educational goal? Or what's the overall goal? How is the learner going to work towards that goal? What is the learner's state of readiness? So where do you need to start? Right? What do you want the learners to know? What experiences will transmit the information? What materials will reinforce your content? Can you just explain it to them? Do you need to give them a video? Do you need to give them written materials? What will help you reinforce that content? How will you know you're successful? And how can you evaluate what or if the learner has learned? So just some general things to think about, and how to be very systematic when you're giving educational activities and educational programs and helping patients to learn. Okay, so we'll talk more of this later. Thanks.